Okay, today we are going to learn about COVID-19. Considering the current ongoing pandemic worldwide, it is quite wise to study COVID-19 for our university examination because it is a quite high yield topic being repeatedly asked in pre-university examination of multiple colleges. So we will start our discussion with etiology and then we go towards transmission, pathogenesis, clinical features and treatment of COVID-19. As we all know that COVID-19 is caused by a virus which is called SARS-CoV-2 virus, SARS standing for Severe Acute Respiratory Syndrome Coronavirus Type 2. Type 1 SARS caused pandemic in 2002 in China. We know that SARS-CoV-2 is a single-stranded RNA virus. Talking about the structure, we can see that it is a single-stranded RNA virus consisting of a core RNA surrounded by a protein coat called capsid. Within the protein coat, there are multiple glycoprotein spikes. And these glycoprotein spikes are called spike protein, also known as S proteins. Now, because of these spike proteins are radiating through the core of the virus, it gives a typical appearance of a petal of flower, or sometimes also known as crown of a king. So this, because of this appearance of a crown or a petal of the flower, it is called coronavirus, and hence the name of corona has come. So you can see that this is an RNA, there is a protein coat, and these are the S proteins. S proteins are particularly important in pathogenesis of the coronavirus because it is through this S protein by which the coronavirus attaches to a particular receptor called ACE2 receptor present in the respiratory epithelium. Right? Okay. Now let's talk about transmission of the COVID-19. We know that the most common method of transmission of COVID-19 is through the aerosols and through the air droplets whenever the person coughs, sneezes or speaks. And the second most common being the direct contact with the fomites or surfaces which are contaminated with the aerosols. There has been a single case in which a live viral virus has been isolated from a stool sample of a case, but till now there has been no evidence of even single fecal-oral transmission. So the most common method of transmission still remains airborne whenever the person coughs, sneezes or speaks, and the second most being the direct contact through the fomites. Okay, now let's talk about the pathogenesis of COVID-19, right? So as I have already said that spike proteins are particularly important in the pathogenesis of COVID-19. So whenever you inhale a respiratory droplet which consists of a COVID-19, what happens is that you get SARS-CoV-2 virus in the respiratory tract. Now this SARS-CoV-2 virus through its spike protein is going to attach a particular receptor which is called ACE2 receptor, right? Okay, so but before attaching to the ACE2 receptor, this spike protein needs to be cleaved and activated, and that function is of a particular protein called TMPRSS2 protein. So when you inhale a respiratory droplet containing SARS-CoV-2 virus, the TMPRSS2 protein present in the respiratory epithelium cleave the spike protein, and after being cleaved, the spike protein gets activated, and then those spike protein attach to the ACE2 receptors, causing activation of the respiratory epithelium, and then it undergoes receptor mediated endocytosis so that the viral particle gets engulfed within the cell inside a vesicle, and after that the virus uncoats its protein capsid and lays down its genome or genetic material, which undergoes transcription, translation as well as multiplication. So you can see here, by this process the virus enters the type 2 pneumocytes. So understand that the ACE2 receptor, the density of ACE2 receptors is maximum in the type 2 pneumocytes. We know that the respiratory epithelium consists of type 1 as well as type 2 pneumocyte. The type 2 pneumocyte is particularly important for the production of surfactant, which keep the surface tension inside the alveoli lower. So the infection starts from type 2 pneumocytes. Now, as the infection progresses, what happens is that the virus multiplies within the pneumocyte, and then finally, after complete multiplication, multiple copies of the virus are ejected out of the cell. And in this process, the cell gets destroyed or damaged. Whenever the cell gets damaged, it causes the release of inflammatory mediators, which are called cytokines. And these cytokines are particularly dangerous for the pathogenesis of the disease, right? So you can see there is damage of type 2 pneumocyte, and due to this damage there is decreased production of surfactant. Whenever there is decreased production of surfactant, there is increase in surface tension, which causes collapse of the alveoli, and after the collapse of alveoli you need an extra energy to pop open those alveoli, and hence it increases the work of breathing, causing respiratory distress. Now, because there is damage of the cell, this damage causes release of inflammatory mediators, particularly interleukin 1, 6, TNF alpha, and GM-CSF. GM-CSF stands for granulocyte macrophage colony stimulating factor. This is an important one and most severe form of inflammatory mediators. Once again, interleukin 1, 6, TNF alpha, and GM-CSF. So these inflammatory mediators, what do? They do is they causes infiltration of the neutrophils and macrophages within the alveoli and in the interstitium. Once these neutrophils and macrophages enter the alveoli and interstitium, they cause damage to the whatever cells that are present there through a release of reactive oxygen species. So they cause damage to both type 1 and type 2 pneumocyte. Then once again, we know that after type 2 pneumocyte there is decrease in surfactant, increasing the surface tension, causing collapse of the alveoli. And because of damage to the type 1 pneumocyte, which are important in the gaseous exchange, so there is decrease in gaseous exchange, which leads to hypoxia, right? So this was the effect of these cytokines within the lung parenchyma. What if these cytokines leak from the lung parenchyma and go to lung vasculature? Then what happens is that it increases permeability of the blood vessels within the lung, as well as it causes vasodilation of the blood vessels of the lung, which ultimately cause increase in fluid coming out of the blood vessel and into the interstitium, causing interstitial edema. And if it goes on further, it can also cause alveolar edema. Okay, so this was it, the effect of cytokines within the blood vessels of the lung. Now, what if these cytokines escape from the lung through the blood vessel and enters the systemic circulation? Well, then you have got systemic inflammatory response syndrome, and finally multiple organ gets damaged and cause multiple organ dysfunction syndrome. So this was the pathogenesis of the worst case scenario of the COVID-19. But all the COVID-19 cases do not develop this pathogenesis. All the cases do not develop hypoxia, alveolar collapse, alveolar edema, as well as SIRS and MODS. Most of the cases, in fact 80% of the cases are asymptomatic or mildly symptomatic, right? So why is this discrepancy? Well, none of us knew the discrepancy in the presentation of this disease up until very recently, in which the role of interferon type 1 was explored. So what happens is that most of the population have proper amount of working interferon type 1, and due to this in working interferon type 1, what happens is that there is activation of early innate immune response whenever a virus infects a single cell. So after infection of a single cell, interferon type 1 gets activated, which causes early innate immune response, and very early in the disease there is activation of neutrophil and macrophages, which clear out this virus, causing damage to a very few number of cells. So whenever there is damage to a very few number of cells, only a small amount of cytokine is produced, and because of this small amount of production of the cytokines, what happens is that you have only asymptomatic or at most mild or moderate COVID infection. But what if I talk about a particular population who has a congenital deficiency of interferon 1, or who is an old aged person, has diabetes mellitus, hypertension, immunosuppressed, or has autoantibody against interferon 1? In all these population, what is going to happen that they will have a decreased density of interferon 1. So if you have a decreased density of interferon 1, what happens is that there will not be early activation of innate immune response. So there is absence of early innate immune response. So due to absence of early innate immune response, what happens is that the virus is not cleared. The virus can no more be cleared early in the disease. So virus replicates unhindered. So when virus replicates unhindered, what happens is that large number of host cells are infected. So whenever large number of host cells are infected, eventually the virus is going to get detected by the adaptive immune response. And then later on, when the adaptive immune response mounts a response against the virus, there is of course there is going to be clearance of the virus, but that clearance of the virus will cause destruction of the large number of host cells. Why? Because virus has already infected large number of host cells, and in effort to clear those virus, you also have to cause damage to the large number of host cells. So whenever there is damage to the large number of host cells, what is going to happen? Once again, there is going to be production of cytokines, interleukin 1, interleukin 6, TNF alpha, GM-CSF, but this time it is going to be large quantity. Why? Because large number of host cells are being damaged, and this leads to a particular phenomenon which is called cytokine storm. So because there is production of such a huge amount of cytokine, interleukin 1, 6, TNF alpha, and GM-CSF, that it causes severe effect on various organs including lungs, blood vessels, and distant organ targets. So what happens in lung is that once again it is going to cause infiltration of neutrophil macrophages, which are going to cause increase in reactive oxygen species, which cause damage to both type 1 and type 2 pneumocytes, ultimately leading to ARDS. Within the blood vessels of the lung parenchyma, there is going to be endothelial damage as well as vasodilation. So there is going to be interstitial edema followed by alveolar edema. In the distant blood vessels, what happens is that through these three main pathogenesis, either through direct endothelial injury or activation of complement system, or through activation of neutrophil within the blood vessels, which throws out multiple fibrotic strings, ultimately causing stasis of blood vessel and then causing clotting of the blood, and then leading to stasis of blood supply through that entire vessels. All these things either through direct endothelial injury or by activation of neutrophil, which causes neutrophil extracellular traps, also known as netosis, or through complement activation. All these three ultimately leads to hypercoagulability. And understand that hypercoagulability is a very important aspect in COVID-19. Well, it is a very common complication of severe case of COVID-19. And finally, if you have such a huge amount of cytokine that you have a cytokine storm, they are of course bound to get leaked out from the lung parenchyma and go to different organs and organ targets, which can cause systemic inflammatory response syndrome and multiple organ dysfunction syndrome. So all these the downward spiral of severe form of or critical form of ARDS or COVID-19 started from the fact that the person was deficit in interferon type 1. So a small recap about interferon. We know that there are two types of interferon, interferon type 1 and interferon type 2. The most heard type of interferon that we often hear in the pathogenesis of tuberculosis is interferon gamma. Well, in fact, interferon gamma is the only type 2 interferon. Most of the other interferon alpha, beta, delta all belong to interferon type 1. And these interferon type 1 are responsible for innate immune response. These are the first cytokines that are released by any kind of cells undergoing damage, whereas interferon gamma belongs to adaptive immune system and comes in the pathogenesis of tuberculosis, right? So this is important. If you have deficiency in type 1 interferon, then innate immune response cannot be mounted, and then only way of clearing those virus remains is adaptive immune response, which is a very delayed response, and by that time virus has multiplied to a large number of host cells, which causes damage to the large number of host cells, causing a release of large number of cytokines and then cytokine storm. So this is the pathogenesis. So difference of why some cases develop only asymptomatic, while some cases become mild to moderate symptomatic, and why some cases goes to having critical pneumonia, critical COVID. Okay, now in between asymptomatic mild moderate COVID and critical pneumonia, there is a severe form of COVID, which is a sort of a middle ground between completely absent interferon 1 and completely normal interferon 1. What happens that in these forms there is slight deficiency or defect in interferon 1, due to which virus cannot be eliminated early, but later on, because of activity of the resident macrophages and dendritic cells, which pick up the virus, act as an antigen presenting cell, present to the local lymph nodes, which cause activation of T cell. T cell causes differentiation of B cell into the plasma cell, which causes plasma cell ultimately secretes antibodies, and these antibodies cause elimination of virus only at expense of slight destruction of host cell, which causes severe COVID infection. So this is the pathogenesis of the three types or three spectrum of disease: asymptomatic mild to moderate COVID, severe COVID, and critical COVID with severe pneumonia. Okay, now let's discuss about clinical features of COVID-19. So one of the interesting feature of this COVID-19 is that it has varied spectrum of clinical features. So it extends from being asymptomatic to mild to moderate symptomatic to severe illness and then critical illness, and finally often causing mortality. Majority of the cases, at around 80% of the cases, are asymptomatic or at most mild to moderate symptomatic without shortness of breath. 15% of the cases are severe illness in which patient develops shortness of breath, often pneumonia, and then resolve spontaneously without requiring much of a treatment. 5% of the cases are very severe form of disease with severe shortness of breath, often respiratory distress requiring mechanical ventilation, and in up to 2% of the cases, there can be mortality. This mortality rate or case fatality rate may extend depending upon the developmental status of the particular community or particular nation, with the rate of mortality being high in developing countries with limited healthcare facility and facilities of mechanical ventilation. Now, what can be the symptoms of COVID-19? So we can see here the symptoms of COVID-19 is that the three main symptoms are fever, cough, and shortness of breath. So shortness of breath, cough, as well as fever, right? Fever. So one important thing in shortness of breath of COVID-19 is that this shortness of breath do not develop early in the disease, they develop quite late in the disease. So if a patient of COVID-19 presents with shortness of breath, then understand that much of the lung parenchyma has already damaged. So this is one differentiating fact of COVID-19 related ARDS with other ARDS. So in other form of ARDS, what happens is that because of damage to the lung parenchyma, there is loss of a particular reflex called hypoxic pulmonary vasoconstriction. So what happens is that if due to any cause there is decrease in ventilation of an alveoli, what happens that the normal phenomenon of our body is to also decrease in perfusion of the neighboring blood vessels, so that the VQ ratio is kept at normal level. But in ARDS, what happens is that because there is damage to the parenchyma, so this hypoxic pulmonary vasoconstriction is also lost. So although there is hypoxia because of decreased ventilation in the alveoli, the perfusion do not decrease, it remains unchanged, and due to this what happens is that the VQ ratio gets mismatched. So there is VQ mismatch. Why? Because ventilation decreases but perfusion still remains normal. So due to this, VQ ratio decreases, and this is called a VQ mismatch, and which exacerbates the conditions. So if there is a VQ mismatch, what happens is that, so there is hypoxia in the alveoli, but the blood vessel, the flow through the blood vessel is still normal. So all the blood carrying deoxygenated hemoglobin passes through the alveoli without getting oxygenated. So this acts as a form of shunt. So the blood from right heart is going towards the left heart without getting oxygenated. So this is a shunt, and ultimately in systemic circulation what is going to happen is that there is going to be hypoxia and there is going to be shortness of breath. So this is any other ARDS except COVID-19. What happens is that there is decrease in ventilation without any change in perfusion, and there is VQ mismatch, and hence shortness of breath occurs. But in COVID-19 what happens is that there is decrease in ventilation. Why? Because there is alveolar edema, right? But at the same time there is also decrease in perfusion. Why? Because we already studied that in COVID-19 there is activation of the clotting cascade, and hence there is accumulation of multiple clot within the blood vessels, and due to this there is also stasis of blood flow. Now there is also decrease in ventilation and there is also decrease in perfusion. Hence, because both ventilation and perfusion decreases, the VQ ratio as such remains maintained, and hence there is no per se right to left shunt, and hence the blood in the systemic circulation do not get desaturated that easily, and hence shortness of breath is a quite late feature. So if a patient with COVID-19 develops shortness of breath, understand that it is a quite advanced form of disease and much of the lung parenchyma has already started deteriorating. So this was one thing, how shortness of breath of COVID-19 is different from any other form of ARDS, right? So another fact of COVID-19 is that the cough present in the COVID-19 is not a productive one, it is non-productive cough. If cough develops to become productive, then understand that there is a secondary bacterial infection or it is a bacterial pneumonia. So these are the common symptoms of COVID-19. Loss of smell, anosmia, or change in taste, or loss of taste, and dysgeusia are not so common features of COVID-19, but they are thought to be very specific feature of COVID-19. They have very high specificity, right? So COVID-19 involves invariably multiple systems of the body, and hence there is often conjunctivitis, at the same time headache. There is also involvement of a GI system, ultimately leads to loss of appetite as well as nausea, vomiting, diarrhea. All these things can also occur in COVID-19. So this particular graph, what it shows is that not only symptoms occur in the acute stages of COVID-19, the patient who get healed from COVID-19 still complains. About half of the patient who get healed from the COVID-19 still complains of the persistence of these symptoms till months later after the person has recovered from the disease. So this is called post-COVID manifestation or post-COVID symptoms, right? Now, to understand the clinical features of COVID pneumonia better, we have to take a look at this graph. So COVID pneumonia can be staged in 3 stages: stage 1, stage 2, and stage 3. Stage 1 is the early infection, stage 2 is pulmonary phase, stage 3 is hyperinflammation phase. So if we look at the pathogenesis of COVID-19, we understand that the pathogenesis starts from viral replication. So there is viral infection. That infection ultimately causes replication of the virus within the lung parenchyma. So there is the initial phase of viral replication. Invariably, the virus is going to get cleared out. Why? Because there is a development of immune response, right? So eventually the virus is going to get cleared out because of activation of inflammatory response. But later on, even after the clearance of the virus, the inflammatory response may persist. And it is this inflammatory response, it is this antibodies and activated neutrophils and macrophages that causes damage to the host cells, right? The native host cells of the lung parenchyma as well as the different organs. And hence the particularly deteriorating or the mechanism that causes severe illness or takes life of a patient is not the viral replication or directly from the virus mediated injury. It is from the response that our immune response mount against that viral infection. So controlling the inflammation is a particularly important thing to prevent the severe morbidity and mortality. And this particular fact also come in handy to direct a particular modality of treatment at a particular time in the pathogenesis of the disease, right? So if a person gets infected at day 0, then the incubation period of the disease is anywhere from day 2 to day 14. At average, the incubation period is at day 5. So patient develops symptoms from day 5. And it is at the day 5 that the patient has maximum viral load, right? And the patient is most infectious. By the time patients become symptomatic, they are very infectious and they have maximum viral load as seen in this graph. And then on, what happens is that the viral loads starts decreasing, right? You can see in this graph. So in this early phase of the disease, in stage 1, all the symptoms that the patient is going to develop is only because of viral proliferation. And hence, if you want to treat the patient in this phase, the effective mode of treatment would be antivirals, right? And not steroids. Steroids do not act as antivirals. Steroids are only going to act in this phase of the disease. This phase of the disease, steroid cannot act in this phase. Why? Because there is no inflammatory component in the pathogenesis of the disease. All you want to do is you want to decrease the viral load. Why? Because the symptoms in this phase of the disease is only because of viral load, right? And what are those symptoms? The dry cough, slight fever, these mild constitutional symptoms are only because of the viral load, and hence you would want to decrease the viral load. And hence the treatment of antivirals like remdesivir or hydroxychloroquine, which prevents the fusion of the virus with the host cell. So hydroxychloroquine, chloroquine, as well as convalescent plasma transfusion. In convalescent plasma, what happens is that there is presence of antibodies against those viruses, and these antibodies causes neutralization of the virus, and hence convalescent plasma is particularly important in the treatment in the early phase of the disease when there is symptoms because of viral phase, right? At the same time, ritonavir, lopinavir is also important in the early phase of the disease when the viral phase is particularly high. And yet, that being said, convalescent plasma, remdesivir are not used in stage 1. Why? Because about 80% of the cases is going to pass through stage 1 and then they are going to resolve spontaneously, and hence wasting your drug like remdesivir or convalescent plasma in stage 1 of the disease, which almost every patient is going to get through, is a waste of opportunity and waste of resources. And hence, although theoretically convalescent plasma and remdesivir is best when the phase is the viral response phase, which is this one, convalescent plasma and remdesivir is not started until patient goes into a severe form of stage, that is a patient develops shortness of breath, that is a stage 2. So, and hence I have written here is that remdesivir and convalescent plasma is only given after patient goes into the stage 2 or pulmonary phase, that's a patient develops shortness of breath. Now, there are some manifestations that are because of excessive inflammatory response. That includes lung parenchymal damage, ultimately leading to shortness of breath and hypoxia, respiratory distress, finally ARDS, systemic inflammatory response syndrome, shock, and cardiac failure. These all were because of excessive production of harmful cytokines, which were interleukin 1, interleukin 6, TNF alpha as well as GM-CSF. So it would be a very insightful thing to do, target these interleukins or cytokines by using monoclonal antibodies against their receptors. And there is in fact a drug for targeting receptors against interleukin 6, and it is called tocilizumab. So these anti-interleukin 6 monoclonal antibodies are used only in stage 3, where there is an excessive inflammatory response. These are some sort of a last sort of medical therapy. So tocilizumab are used in cytokine storm, right? If there is cytokine storm, there is ARDS, SIRS, and cardiac failure, right? And tocilizumab is a monoclonal antibody which is against interleukin 6 receptor, right? And how does one know that there is a cytokine storm? You can predict cytokine storm by measuring these 4 things in the blood. If there is increase in ferritin, increase in CRP, increase in the level of interleukin 6 as well as D-dimer. D-dimer increase indicates there is coagulopathy, and coagulopathy is because of cytokine storm. And hence, if there is 4 of these findings, it indicates cytokine storm, and it will be a right time to treat with tocilizumab. At the same time, you can also start treatment with steroid. Steroid are anti-inflammatory drugs, right? And hence treatment of steroids should start in those patients who have respiratory distress at rest or who requires mechanical ventilation. That is to say, stage 2B. From stage 2B onward, you would treat with steroid, right? So these were insight into the medical treatment on the basis of clinical features. So understand that these are all the clinical features. Understand that these clinical features do not all occur at once. You can divide the disease process into multiple stages. In stage 1, there is only viral multiplication, and hence there is only some clinical features like fever, dry cough. Whereas in stage 2, there is viral response as well as inflammatory response, and hence the symptoms are particularly worse. Shortness of breath also develops. Finally, in stage 3, there is cytokine storm, ultimately leading to ARDS, SIRS, and cardiac failure. And hence, understanding the stage of the clinical feature also lets you to direct a particular medical treatment in these phases. In stage 1, you would want to treat with antivirals. You can also use zinc and hydroxychloroquine. Zinc are epithelioprotective. Hydroxychloroquine prevents entry of the virus in the cell. And zinc also does the same. They are epithelioprotective, right? Whereas you would wait until patient goes into stage 2 to start convalescent plasma and remdesivir. Why? Because these are costly facilities, right? And finally, if the patient goes into stage 2B and 3, you would use anti-inflammatory, which include steroids, as well as finally interleukin 6 antagonist, which is tocilizumab. It is the same thing given once again here. Stage 1, stage 2, and stage 3. Early infection, pulmonary phase, hyperinflammatory phase. In early infection, you can give antiviral like hydroxychloroquine, remdesivir, right? Okay, in stage 2, you can give convalescent plasma as well as antiviral. Finally, from stage 2B, you start steroid. And finally, if the patient goes in stage 3, you can try tocilizumab, which is helpful if the patient goes into cytokine storm. It is an interleukin 6 antagonist. It's the type of monoclonal antibody. So that would be clinical features of COVID-19 corresponding with their management. So now let's talk about the diagnosis of COVID-19. So we all know that for the diagnosis of COVID-19, what we do is RT-PCR. RT-PCR stands for real-time PCR, sometimes also called reverse transcriptase PCR, but the better one would be real-time PCR, right? RT-PCR works on the principle of DNA amplification. What we need to understand is that polymerase chain reactions can only identify DNA. And hence, if your virus is RNA virus, what you need to do is first you need to convert RNA into DNA and then amplify that DNA and then finally detect that DNA. And hence there is a use of particular enzyme called reverse transcriptase enzyme. Reverse transcriptase is an RNA dependent DNA polymerase. So it utilizes the RNA of the virus and then convert that RNA into DNA. And then finally the DNA is multiplied or amplified multiple cycles so that it becomes detectable by the machine. And once it gets detectable by the machine detects the particular DNA associated with that virus, and then it gives a test which is said to be positive. So what normally happens is that you collect a sample in a nasopharyngeal swab. That sample is used by the RT-PCR machine. The RNA, if RNA is present, if the viral RNA is present, that RNA is converted into DNA, and then that DNA is multiplied or amplified multiple cycles. Now, what RT-PCR machine does is that in any sample, it multiplies or amplifies up to 40 cycles. So if there is no DNA detected up to 40 cycles, then the RT-PCR machine labels the sample as negative, right? But if DNA is detected within 40 cycles of amplification, then the test is said to be positive. Now, the number of cycles of amplification that was required for the DNA to get detected is called as CT value. CT standing for cycle threshold. So if CT value is higher, so higher CT value is arbitrarily understood as CT value that is more than 12. So if CT value is higher, it means that the machine had to amplify the DNA more than 12 times so that it becomes detectable by the machine. That is to say that whatever sample you took had a very trace amount of virus. So that indicates that it had a very low viral load. So if a patient has very low viral load, the patient is not infective. The patient is very less infective, right? But if CT value is less than 12, it means that within amplification less than 12 cycle, the virus is detected. That is to say that there is a high load of virus within that sample, right? So low CT means there is high viral load in the sample. If there is high viral load in the sample, it indicates that there is high viral load in the patient. If there is a high viral load in the patient is highly infective. So that's the significance of CT value. Okay. RT-PCR is a quite sensitive and specific test, and it is the best test for the diagnosis of COVID-19 virus up until now. Sample is collected from nasopharyngeal swab. Another sample is taken from oropharyngeal swab. There is another test which is a rapid antigen detection test. It is a rapid test because it provides result within 30 minutes. So rapid antigen test does not detect the nucleic acid, it detects viral antigen. Antigens are proteins, right? So especially two proteins are used for the detection by rapid antigen test. These are spike protein and nucleoprotein. The spike yes protein I talked about earlier in the pathogenesis of the disease. The one problem with rapid antigen detection test is that it has a low sensitivity. The sensitivity of the rapid antigen test ranges from anywhere from 30 to 80%. So it is not that reliable in terms of sensitivity. But the low sensitivity can be explained by the fact that it requires a very high viral load for detection. So if a patient has a low viral load, then it can have a false negative report. But this antigen test, because it being very cost effective as well as it giving a very rapid result within 30 minutes, it has a value in public health point of view. Those states in India which had early rapid antigen detection tests instead of waiting for PCR had a better outcome than those states which waited for the PCR reports. Okay. And the result is given in the form of a strip. This was the rapid antigen detection test. Another test is rapid antibody detection test. It is also a rapid test, but it detects the antibody that our immune response makes against the virus. Hence, it has a very low sensitivity, lower than the rapid antigen detection test. The sensitivity is low. Why? Because antibody appears in our body only late in the disease, after 3rd to 4th week. By the time antibody appears, the virus has already get cleared and the patient has become asymptomatic once again. The patient is in the healing curve, and hence rapid antibody detection test can only detect either healed cases or in the late presenting cases, right? Antibody detection test is not that much effective, right? Okay. So these are the tests for the diagnosis of the COVID-19. There are other tests which can be done in patient who presents with COVID-19. If you do complete blood count, then COVID-19 cases will have lymphopenia, right? The lymphocyte count will be low. And chest X-ray and chest CT are particularly used for prognostication of the disease as well as to check how the disease is progressing. So if you do chest X-ray in the case of COVID-19, because COVID-19 causes ARDS, all the typical finding of ARDS will be present in the chest X-ray as well as in CT scan. The typical finding of ARDS being ground glass opacity with air bronchogram, as well as there is interstitial edema, and finally features of lung collapse. You can see in this X-ray there is dirty, hazy appearance of ground glass opacification. There is ground glass opacity, right? and at the same time you can see there is presence of air bronchogram. So these are all air bronchograms, right? So ground glass opacity with air bronchogram with features of interstitial edema and finally features of lung collapse indicate ARDS. And CT scan will also be similar to the findings in the chest X-ray, right? And while monitoring the case of COVID-19, especially the severe cases or critical cases, it is very important to know has the patient progressed into cytokine storm, or has the patient gone into critical type of COVID-19 or critical pneumonia. To know that, we can use these following 4 markers to detect if the patient has gone into cytokine storm. So once again, I have already talked in the topic of tocilizumab that if the patient has increased CRP, C-reactive protein, if the patient has increased ferritin, increase in level of interleukin-6 and increase in D-dimer, it all indicates that the patient has gone into cytokine storm, and these patients require aggressive treatment with tocilizumab. Okay, so these were all the diagnostic tests as well as prognostic tests as well as tests for monitoring cytokines that are used in the cases of COVID-19. Now let's finally talk about the treatment of COVID-19. So you can classify the COVID-19 cases into 2 classes. So if the patient is asymptomatic or the patient is mild to moderate symptomatic, that is to say patient has all the symptoms but not shortness of breath. So if the patient has any symptom but does not have shortness of breath, then it is automatically mild to moderate symptomatic. And the patient does not belong to high risk group. Who are the high risk groups? Any patient more than 65 years of age, right? Any patient who is more than 65 years of age, the patient having diabetes mellitus, hypertension, coronary artery disease or immunosuppression are automatically high risk group, and they are at higher risk of developing severe or critical pneumonia. Why? Because in all these cases there is a defective innate immune response, the story of interferon type 1. So all these patient has defective immune response, defective innate immune response, and hence these are high risk of developing severe form of disease. So a patient who is asymptomatic, mildly symptomatic and does not belong to high risk groups, that is to say has age less than 65, there is no diabetes mellitus, hypertension, coronary artery disease or immunosuppression, in this case you can treat the patient at home isolation. This patient should be kept in home isolation and supportive management is required. For fever, give paracetamol, ask the patient to do daily exercise, ask the patient to drink plenty of water, maintain hydration, right? Ask the patient to do chest physiotherapy and chest exercises, right? And explain the danger signs of the disease. Explain that whenever the patient develops shortness of breath, then the patient need to present to the hospital. Ask the patient to measure daily body temperature, right? Yeah, and in some cases the patient may be prescribed vitamin C, vitamin D, zinc may be tried because all these vitamins have been thought to be protective against viral proliferation, but they are not proven for sure. Right now, if the patient is moderate to severe symptomatic, or if the patient belongs to high risk group, that is to say the age of the patient is more than 65, the patient has diabetes mellitus or hypertension, or the patient has any coronary artery disease, or the patient is immunosuppressed, right? These are high risk group, and these cases need to be admitted to the hospital. Once in the hospital, check the SpO2. If the SpO2 is less than 93, start the patient on oxygen. Always try to maintain SpO2 more than 93, except if the patient has a comorbidity, that is to say COPD. In COPD, try to maintain SpO2 from 88 to 93%. Whereas in all other cases, the patient who does not have COPD, try to maintain at higher than 93%. If SpO2 decreases, start with oxygen through high flow nasal cannula, right? Okay, and patient also requires other supportive management. So for fever, give paracetamol. Also maintain adequate hydration, right? Ask the patient to be in prone position. This is called prone position nursing. Prone position nursing is very important in COVID-19 patient. Why? Because keeping the patient in prone position, what happens is that there is a recruitment of additional lung parenchyma, which are normally not used by a normal individual, especially in supine position. The dorsal, if the patient lies prone in the prone position, what happens is that the dorsal lung parenchyma, which was never used by the patient for breathing, gets also recruited, and this recruitment helps in maintaining proper ventilation of the alveoli. And another fact is that if you lie supine, the weight of the heart itself compresses some lung parenchyma and causes alveolar collapse. So if you lie prone, there is no more weight of the heart compressing the lung parenchyma, and hence there is increase in the alveolar volume for the ventilation. So patient requires prone position nursing as well as ventilation. So even if later on you decide to ventilate this patient with endotracheal tube, you would want to do it in prone position, right? So for prone position nursing, the method of doing prone position nursing is that for 30 minutes to 2 hours, keep the patient in prone position. Then for next 30 minutes to 2 hours, keep the patient in right lateral position. Then for next 30 minutes to 2 hours, keep the patient in left lateral position. And finally, for the last 30 minutes to 2 hours, keep the patient in sitting up position with 30 to 60 degree tilted up angle, right? And then once again go back to 30 minutes to 2 hours of prone position. And every 15 minutes, keep on checking SpO2, right? If SpO2 decreases, change the position. So this was the method of doing prone position nursing. So understand that there is difference between prone position nursing and as well as prone position ventilation. In prone position nursing means that the moment patient gets admitted in the hospital, from then on prone position is started. So without even ventilating, if the patient is completely normal, even if the patient is completely normal and is not in shortness of breath, not ventilation, ask the patient to be in prone position for 30 minutes to 2 hours, and then in right lateral position for 30 minutes to 2 hours, and then finally left lateral for the next 2 hours, and then sitting up position for of 30 to 60 degree angle in the next 2 hours. So this is prone position nursing. But if the patient develops severe respiratory distress and you want to do endotracheal intubation, the endotracheal intubation itself is also done in prone position. So that is called prone position ventilation. Both of them are important. Why? Because there is recruitment of dorsal lung field, as well as there is decrease in the pressure applied by the heart in the supine position. All these things decreases the dead space and increases the ventilation. So prone position nursing is very important in COVID-19, right? Now keep on checking D-dimer. So if D-dimer is high, understand that there is coagulopathy. Patient is going into cytokine storm. So if the D-dimer is high, the patient is developing coagulopathy, then treat it with low molecular weight heparin. It is very important to avoid disseminated intravascular coagulation. Now various medications has been tried in this past 1 year they all have been tested for the efficacy. Initially, hydroxychloroquine was very famous in the early phases of the pandemic, but now it has been proven by Solidarity trial conducted by WHO that hydroxychloroquine has no response or no effect at all in the disease process. Remdesivir has been FDA approved. It is an FDA approved drug for the treatment of COVID-19. Lopinavir, ritonavir are protease inhibitors used for HIV and hence has also been tried for COVID-19. Ivermectin, like hydroxychloroquine, has now been shown to be not effective at all. Steroids are very important for the treatment of not the early cases, the late cases after stage 2B. Why? Because it is after stage 2B that there is excessive inflammatory response, which can be avoided if you use steroid, right? And plasma therapy, convalescent plasma therapy can also be used in stage 2. And finally, if it is a very severe form of disease, that is to say the patient goes into stage 3, then you can use tocilizumab. How would you know that the patient is going into stage 3? You will check is the patient in cytokine storm. Check once again, check interleukin 6, check the level of D-dimer, check the level of ferritin, check the level of C-reactive protein, right? And if those are high, understand the patient is in cytokine storm, treat with tocilizumab. Now these were all medical therapies for COVID-19. If the patient is still persistently, the SpO2 if is still persistently very low, switch from nasal cannula to face mask. And then if SpO2 is maintained, then keep on face mask. If SpO2 is still decreasing, then change to Venturi mask. And if the patient is still low SpO2, perform endotracheal intubation and give mechanical ventilation. Mechanical ventilation in cases of COVID-19 is done by using a protocol called ARDS protocol. Ventilating mechanically a patient of ARDS is very different from a patient who is not suffering from ARDS. So it is very important. Why? Because in ARDS there is also damage to the lining alveoli. In ARDS, there is damage to the lining alveoli. So if you give a mechanical ventilation that is very at a higher pressure, if you have a very higher tidal volume, what happens is that because of overinflation of the alveoli, there is shear stress on the lining of the alveoli, which causes damage to the already damaged alveoli. And hence, it is in ARDS that ventilation should be done at lower tidal volume. That is to say, the ventilation is done at 6 ml per kg in ARDS, whereas in non-ARDS cases, it can be done up to 12 ml per kg. And so is the case even in COVID-19. If the patient is gone into ARDS because of COVID-19, the ventilation should be low tidal volume ventilation at tidal volume 6 ml per predicted body weight. Now, let's explain the method of mechanical ventilation in ARDS of COVID-19. So, once again, a method of mechanical ventilation in ARDS of COVID-19 and ARDS of any other disease is slightly different. It is different in the fact that the prone position in ARDS of COVID-19 is used quite early. Even before starting lung ventilation, you would use prone position, right? This is called prone position nursing. So you will use prone position nursing, and then you will do mechanical ventilation, and then this ventilation is also done in prone position. So in other ARDS, prone position is done only if PaO2 by FiO2 ratio becomes less than 150. Then only prone position ventilation is done. Whereas in ARDS of COVID-19, prone position is adapted quite early on in the disease. Even if the person is apparently normal, the person is advised to be in prone position for at least 2 hours, and this is called prone position nursing. And then even if the patient goes into intratracheal intubation, the intubation is also done in prone position. Except for that fact, all the stepwise approach of ARDS in COVID-19 is very similar to any other ARDS. You start at lung protective ventilation. Lung protective ventilation is that tidal volume is low, that is to say 6 ml per kg at maximum. Peak in expiratory pressure is anywhere from 5 to 12 centimeters of water. And PEEP plateau is less than 30 centimeters of water. And SpO2, if the patient is if the patient is also comorbid with COPD, then 88 to 93%, whereas in other cases more than 93% is maintained. Now this is called lung protective ventilation setting. In lung protective ventilation setting, the PEEP is 5 to 12 centimeters of water. Now, if in lung protective ventilation setting, the patient is still maintaining PaO2 by FiO2 ratio is still falling, then you can use high PEEP strategy. That is to say, you can increase peak in expiratory pressure by more than 12 centimeter. So then you would do a high PEEP strategy. If still the patient is deteriorating, then you would give neuromuscular blocking agent like cis-atracurium, right? Why cis-atracurium is given is that imagine you are ventilating a patient. The machine is breathing for the patient. Now, if on top of the machine being major driver for breathing of the patient, if the patient also breathes voluntarily, then there can be a condition in which the direction of airflow because of inhalation by patient can oppose the direction of airflow because of suction of the machine. And due to this dyssynchrony or asynchrony between the voluntary breathing of the patient as well as involuntary flow of air because of ventilator, what happens, there can be volutrauma as well as barotrauma to the alveoli, and to avoid that, neuromuscular blocking agent is used. So if you use a neuromuscular blocking agent, there is complete respiratory paralysis, and hence after complete respiratory paralysis, the same endotracheal tube ventilation will work much better because there is no more any resistance offered by the contracting muscles. So neuromuscular blocking agent can be added if the PaO2 by FiO2 ratio is further falling. And after that, if the PaO2 by FiO2 ratio is further falling in ARDS, then recruitment maneuvers can be done. One of the recruitment maneuver, it has already been done, that is prone position. In prone position, what happens, that dorsal lung parenchyma are recruited, right? Another recruitment maneuver that can be done is using a constant pressure, CPAP pressure, for 20 to 40 seconds, in which the lung is constantly inflated at one pressure, and then going back to the normal ventilation pattern of endotracheal intubation can be done to recruit those alveoli that has been permanently collapsed, right? And even if that does not work, you can use something called high frequency oscillatory ventilation. In high frequency oscillatory ventilation, what is happening that tidal volume is further decreased from 6 to it decreases from 6 to 1 to 3 ml per kg. This decreasing tidal volume further decreases the shear stress on the lining of the alveoli, and this decreases the damage to the alveoli, and hence may inhibit or stop the pathogenesis of ARDS. Finally, you can use inhaled nitric oxide or any pulmonary vasodilators, right? If you use inhaled nitric oxide or pulmonary vasodilators, what happens is that they improve ventilation to perfusion. So if you are using endotracheal intubator, what you are doing is you are ventilating an alveoli. But not only do you want increase in ventilation, you also want increase in perfusion to the same alveoli which is being ventilated. Because if you are ventilating an alveoli, the alveoli is inflating, but the blood vessel is completely constricted and it has no any flow through it, then there is no point of inflating that alveoli. It is a waste work. So to avoid this wasteful work or waste of energy of inflating those alveoli which does not have any vasodilation or blood supply, you would want both. You would want ventilation as well as proper perfusion. So what you can do is you can ventilate with air that has nitric oxide in it. So if the air has nitric oxide, the nitric oxide dissolves through the alveoli and causes vasodilation of the same blood vessel, and this increases ventilation as well as perfusion, maintaining the VQ. So preventing VQ mismatch. So inhaled nitric oxide can be given. Finally, even if this does not work, you can give a complete rest to the lung and use extracorporeal membrane oxygenation, in which another device is used to exchange gases, that is ECMO. So this is the management of ARDS in COVID-19. Except for the fact that prone position is started from early, the ARDS of COVID-19 management is very similar to any other ARDS. Start with lung protective ventilation, which is at low tidal volume, and then if it does not work, go to high PEEP strategy. If that does not work, give respiratory paralysis. If that does not work, start recruitment maneuver. If that does not work, give high frequency oscillatory ventilation. If that does not work, increase vasodilation by inhaled nitric oxide, and finally go for ECMO, right? So for the sake of explanation of physiology, what happens is that in mechanical ventilation, if suppose this is PEEP pressure, this is even at the end of expiration, the pressure is maintained so that the alveoli does not collapse on itself. Then as the machine pushes air into the alveoli, the pressure rises and reaches a peak, and this is called peak inspiratory pressure. This is PEEP, and then machine stops pushing any air. Now as the machine stops pushing any air, the pressure falls, right? And falls and remains and develops a plateau, and this is called plateau pressure. This is called PEEP plateau, also known as P-plat, right? So the pressure of P-plat in a patient of COVID-19 or any ARDS should be maintained at less than 30 centimeters of water. So P-plat should be less than 30 centimeters of water in ARDS, right? And then as the air is once again sucked out of the alveoli, the pressure further falls, but completely air is never sucked out, so that this pressure, which is still above 0, is called peak end expiratory pressure. So this PEEP avoids lung collapse. So this is how ventilation in case of ARDS due to COVID-19 is done. And by that we have explained the etiology, transmission, pathogenesis, clinical feature, and finally the most tedious one, treatment of COVID-19.